Right, welcome everyone. Before we get started, I'd just like to acknowledge the traditional owners of the land that I'm joining you from today, Whadjuk country. I know some of you might not be in the same place given we're on a webinar, so I just want to pay respects to the elders of this country of Australia, pay our respects to the elders past and present, and acknowledge their continuing connection to culture and lands. Welcome to WACOSS Wednesdays at 1. These are what we hope will be an ongoing free weekly webinar series about key topics facing the community services sector in WA. In this first series, we're inviting input and engagement from our members and from the broader sector into our initial thinking of what an inclusive plan for recovery needs to look like for Western Australia in order to make sure that we leave no one behind. Each webinar features a presentation from WACOSS and some of our key partners, followed by some opportunities for conversation and for feedback. So we use the breakout room function a little bit later on. In terms of Zoom etiquette, I would just ask you to remain on mute. Please do keep your video on because it's lovely to see your faces, but understand if technical challenges mean you can't. We encourage you to use the presenter view, although that is a less relevant piece of advice once we have the screen sharing in play. But presenter view generally just makes sure that the person speaking is the biggest one on your screen. And if you could just, for the later part of the session, be prepared to participate in the conversations. And so we, as I mentioned before, use the breakout rooms. And so having the capacity to actually speak and participate as part of those is really valuable. In the feedback we've had today, people will find that almost as valuable as the content sharing itself. So for this session on social isolation, we have 4 key peak partners in the WA Association for Mental Health, the WA Network of Alcohol and Other Drugs, Linkwest, and the Women's Council for Family and Domestic Violence. So I'll introduce you to each of the CEOs in turn, who will brief you from their different perspectives. So it's a busy session, and so I'll hand you directly over to Jenny Gray, the Deputy CEO of WACOSS, and Alex Hughes, the 100 Families WA Project Manager, to kick us off with some opening statements. So Jenny and Alex.
Thanks, Kylie, and hi everyone. Great to be here. As Kylie said, I'm going to just give an overview and do some context setting before I pass to my colleagues from the other peaks for a more nuanced analysis. I thought I would start with some quick definitions just to make sure that there's some shared understanding amongst us. Simply speaking, social isolation is the non-participation of an individual or a group in society's institutions and community activities and so on. Social exclusion is what happens when the reason for someone's social isolation is beyond their control. So we know from research that more than 1/4 of Australians feel lonely due to social isolation and or social exclusion for at least 3 days each week. I think it's really well documented and we all understand that there are significant health impacts, consequences and costs on social isolation. And you can see there on the screen some of those. Chronic loneliness is akin to smoking amazingly 15 cigarettes a day, and loneliness and social exclusion impact our health system to the same degree as obesity does. The poor mental and physical health outcomes associated with feelings of not belonging include, and you can see it again there on the screen, high blood pressure, high cholesterol, diabetes, dementia, Alzheimer's, depression, alcoholism, injury and violence, to name just a few. Despite what we know, we continue to rely on medical interventions to tackle these growing problems, and even despite knowing that social integration and support are cheaper and more effective forms of intervention. And we also know that unaddressed social isolation, exclusion and loneliness can be self-perpetuating and lead to even greater problems. Next slide, Ashley. Thanks. So these 2 lists are worth looking at side by side. On the left side are groups who are more vulnerable to living with food insecurity. And food insecurity is driven by inadequate income. So in other words, people who live with poverty. On the right-hand side are groups of people who are more likely to experience social isolation, exclusion, and loneliness. While these lists could be more detailed, and there are some omissions, the connection between the two is unmistakable. There is a double disadvantage happening here, the link between poverty and social isolation. In some categories, people who are socially isolated are also more likely to live with stigma. For example, people who are unemployed have been shown to use withdrawal from social networks as a strategy to manage feelings of social shame. Despite recent improvements, the social stigma faced by LGBTQI+ people remains a driver of marginalisation and isolation. People who are incarcerated also face an increased loneliness due to physical isolation, obviously. And I think that's worth keeping in mind in the context that Western Australia's prison population has increased by 85% since 2008, despite a population growth of only 20% in that time. And we know that some groups in particular are impacted. We've seen the female prison population grow by 182% in the last 10 years. And we know that isolation in prison impacts disproportionately on Aboriginal people in custody and is directly linked to suicide and self-harm. And another group, probably just worth noting to round up, is the social isolation and loneliness increasingly experienced by older people, especially as our population is ageing. Older people are much more likely to live on their own and less likely to go out, which is a real problem when you combine that with declining mobility and inadequate income. So now I'm just going to pass to Alex, who's going to give an overview of some recent research findings from the 100 Families WA project.
Thanks, Jenny, and hi, everybody. So I've got a couple of minutes, so it's going to be quite quick. So these are just some key findings that will help give some context to the situation families in disadvantage find themselves and contribute to social isolation. So if you don't know what 100 Families is, it's an action research project working with 400 families over the last year and a half to find out through their experiences what their life is like in hardship. So some background stuff. So from the 400 families that we engage, we know that this is all prior to COVID. Our COVID stuff is coming out very soon, next week. But prior to COVID, 13% of the families were employed. So that was a lot of underemployment and casual employment. So that's likely to have changed. 80% were unemployed. So that's a lot of people at home, first of all. Then a couple of key stats with mental health. Almost half have experienced or are experiencing on a day-to-day basis moderate to severe anxiety and depression. So that's huge. And in terms of a trauma history, current and previously, 43% ran away from home before the age of 18, almost a quarter were in active home care, and over 3/4 experience or have experienced domestic violence. So really big stuff, and that's just the tip of the iceberg that I picked out. Now, in terms of social health, first of all, talking about infrastructure, we found in terms of telephones, internet, families, 9% don't have a telephone, smartphone, or landline. A third don't have any internet, and just over a third don't have a car. So the infrastructure is not there to allow them to connect in the first place. And that translates into almost a third are unable to go for even once a month to meet a friend or family member for a drink or a meal. And they're unable to, or a quarter, are unable to provide for their children to enjoy leisure activity. And these are compared to, as you can see, the general population, which obviously are very low. Can I have the next slide, please? Thank you. So what does that look like? In terms of families' ability to connect to others and seek support, I won't go through all those ones, but in the yellow, which is obviously the no column, in terms of things like advice and emotional support, there's a significant proportion of people who are unable to reach out to somebody for key things like that. So not only have you got a vulnerable group of people with a trauma history and complex needs, a lack of resource, whether it be income or infrastructure like phones and cars, but you've also got a significant amount of people who don't have other people that they can connect to help manage those needs. And that is an impacting cycle, if you like. So it just gets worse and worse and worse. And like I said, these are all pre-COVID. So as of next week, we'll be finding out, we'll be able to share with you what it's like actually during COVID. And there's more on that information later, which Kylie, I think, will wrap up with. Was that 2 minutes? I think I did well to get all that in.
You did do well. Next slide. Thanks, Ashley. Okay, I'll just finish up by saying that we all know that the pandemic has exacerbated these groups' experience of social isolation, exclusion and loneliness. There has been the literal forced physical isolation as we've gone through different phases of social distancing rules and border closures. People's mobility and opportunity to socialise and connect with community has actually been restricted. Sadly, we know only too well that those whose health is already compromised, whether through age, disability and or a pre-existing illness, have had to take additional precautions to isolate. And we know, we see it on the media every night, that this means some have literally been hidden from view. During this time, we've relied on digital access to connect to communities instead. And we also know that not everyone's access is equal. Ever increasing levels of unemployment and job insecurity and the growing threat of living without sufficient income is anxiety producing and contributes to social isolation, exclusion and loneliness. And the anxiety for those living with psychological distress, including victims of trauma, has certainly deepened since the onset of the pandemic. And the other presenters will go into this in more detail. Thanks, Kylie.
Thanks, Jenny, and thanks, Alex. That was a really great overview to kick us off. I'm now going to ask Taryn Harvey, the CEO of the WA Association for Mental Health, to talk to us a little bit about the impact of the pandemic-induced social isolation in relation to mental health. So, Taryn.
Thank you, Kylie, and my apologies for not having a slide for you today, everyone. Look, I'm going to talk about the mental health impacts in that broader concept of social isolation and the cumulative impact of all of those social determinants of mental health, which include loneliness, but also those pre-existing disadvantages that many people face in terms of income security, employment, and existing social opportunities. So some of the early trends we started to see in WA, if I can start very locally, is that you know, as Jenny indicated earlier, that many people with mental health issues, like other vulnerable groups, actually isolated themselves a lot earlier than other people did. Some people actually found, we're hearing that, you know, some people actually found that opportunity to be isolated actually helpful because it might have removed them from some settings where they felt pressure. But most people reported, you know, that impact of that heightened awareness and anxiety around their health. And so we know for people with many pre-existing issues, that was a significant impact and exacerbated people's existing limited connections. And we know that our sector played a very proactive role in identifying and responding to people that they identified were at heightened risk of that social isolation and loneliness, particularly in an environment where all of the connections that people might have had in terms of their other mental health supports, for example, might have been moving into a telehealth environment. Many parts of our sector were really keen to make sure that there was some ability to maintain some connection, physical connection for those people, and to do it safely where they were identifying existing challenges. But the other, I guess, the new impacts we're seeing is that the international evidence, the national evidence, and we don't yet have any locally driven modelling to try and understand those impacts. But we know that the cumulative impact of the COVID crisis and the ongoing uncertainty is shifting many people along a mental health spectrum. So people who might have had, and perhaps some of the 100 families who might have pre-existing moderate to severe anxiety and depression, many of those people are being tipped into more persistent levels of mental health issues, and the projections that have been done have started to try and anticipate what the impacts of those effects will be on our system. So here in Australia, a couple of the sources of data that we at WAM have been referencing primarily are the Brain and Mind Centre at Sydney University. So they looked at integrated economic and mental health data to particularly try and measure some of the suicide risks that we might see increase in Australia. And Origin did some particular focuses on young people to look at what the anticipated levels of new presentations of mental health disorders will show. And I'm sure many of you will have heard about the news out of Victoria that actually presentations into hospitals from young people self-harming are on the increase. You will remember in WA that, you know, in the early days when people were taking that social isolation messaging very seriously, the government was actually celebrating the fact that people weren't showing up to emergency rooms in distress. Now, what we know from those experiences is that while they weren't presenting to emergency because people were concerned about infection risks, we know that those experiences of distress were still sitting with people, and I think we saw that that only lasted for a very short period of time. And once people started presenting again, actually the figures kicked up very, very quickly. So the Sydney Brain and Mind Centre, and I'm sorry that this data isn't more potentially positive, but the Brain and Mind Centre data showed that they expected that nationally suicide rates could spike something to an increase of something between 750 and 1,500 deaths a year. So if we recognise that we know there are locations in our state where people are already experiencing heightened risks because of a range of social determinant impacts, you know, we can start to anticipate where we might see some of those impacts here. So that's an area of great concern. And the Origin work looked at things like, their work was very specifically focused on Victoria, but their estimates were that an additional 370,000 Victorians, including 82,000 young people, would experience significant mental distress. And of course, the longer that experience of distress goes on and the longer the uncertainty, the more likely it is that that period of distress will actually contribute to a more persistent and ongoing mental health issue. We've made some efforts based on the demographic data to try and anticipate what those numbers might look like today. I probably won't share them today, but we are certainly urging the state government to try and do some work around trying to anticipate what some of those impacts will be here. Because I guess our primary concern, like in many other of our service systems, is our concern that the supports that we have currently in place are not configured to be able to help mitigate that risk and respond to particularly emerging trends around increased presentations with distress and recognisable disorders. We know that we have a system that really drives people towards acute crisis interventions and people showing up in hospitals, and we've been pushing for a long time for that focus to shift into prevention and the things that will help people as we recover really reconnect with the things that we know counteract social isolation and wellbeing, because the economic scenario has shifted, you know, considerably, and we know that one of the areas that we need to focus on as soon as we can is start to connect people, particularly young people, with employment opportunities as they emerge. And there's been some great ideas thrown around the way that we can connect the various kind of support structures that people need. The other thing, I guess, around the mental health impacts is this is a long tail. There's going to be a long tail to these impacts, yeah, once we have a better handle on what those trends will look like in WA, I think we can look at some better opportunities to work together to try and mitigate some of those risks.
Great. Thank you, Taryn. I'm going to pass on now to Jill Rundle, the CEO of WANATA. So Jill, I'll pass over to you.
Thank you. Next slide, please, Ashley. Okay, so before I start, I'd like to acknowledge the traditional owners on the lands where we're all meeting today, paying respects to elders past and present. Been privileged to work at WANATA, the peak body for alcohol and other drug services in Western Australia, for over 20 years, and in the alcohol and other drugs for over 30 years. So in 5 minutes, I'd like to talk about social isolation, how it's been exacerbated during the pandemic, and how this relates to alcohol and other drugs. So I'd like to start first by looking at the impact of the pandemic on sector staff. So WANATA offers an umbrella EAP, or Employee Assistance Program, to staff in the sector. The quarterly EAP report for April to June 2020 compared with the same period in 2019 shows more than 100% increase in staff presenting with social isolation concerns. For example, the presenting issue for staff accessing EAP saw isolation increasing from 11.7% to 23.5%, social connectedness increasing from 13.3% to 29.4%, Family separation increasing from 6.7 to 14.7%. In addition, issues that contribute to, as Jenny said, and arise from social isolation, such as experience of childhood trauma, neglect, abuse, have all similarly increased as a primary presenting issue for staff accessing the EAP. I think we all need to look at strategies at supporting community sector staff in relation to social isolation. It's important for all of us to consider that. So next slide, please, Ashley. For people with problems associated with the alcohol and other drug use, social isolation concerns with or without a pandemic are common factors. As this first dot point highlights, establishing a therapeutic alliance and addressing social connectedness are two key indicators for successful outcomes for individuals accessing treatment. Loneliness, disconnection, social isolation experiences for people with problems associated with alcohol and other drug use is significantly impacted by stigma and discrimination. So illicit drug dependence is internationally recognised as the most stigmatised health condition. Stigma and discrimination discourages help seeking from individuals needing to access a range of services, and this obviously continues to apply even in times of crisis. If you or your services are seeing people with problems associated with alcohol and other drug use, it's okay to ask questions about their use in a non-judgmental way, support any decisions to make positive change, and to know how to refer them if treatment is needed. Next slide, please. So WANATA has an active survey determining the impact of COVID on the WA alcohol and other drug treatment service users. We should have the results of that survey in about a week. In the meantime, a survey of service users in Victoria has highlighted the impact of the pandemic, including social isolation concerns. For example, as per Victoria, WA non-residential services have offered digital access treatment, and as Taryn also highlighted for the mental health service sector. There have been some positives as per the Victorian survey for digital access, easier, increased participation by individuals already engaged. This has, however, resulted in less access capacity for new service users. Digital access is not ideal for many, in that it makes the establishment of a therapeutic alliance and supporting connectedness more difficult. Group therapy sessions have been impacted most. Increased isolation has seen increases in relapse or lapses in alcohol and other drug use as well, for many. In WA, WANATA has also received reports of overdose deaths of people on service wait lists. Next slide, please, Ashley. So the pandemic saw a reduction in the availability of some drugs, impacting on the drugs' purity and their price. There have, however, been no availability barriers and reported abundance of some drugs during this pandemic. Some people have changed their drug of choice during this time. All of these factors increase risk and the potential harms. Alcohol has remained readily available with increased access supported through promotions of home deliveries. Alcohol advertising at times has gone viral, normalising this drug as a solution to social isolation. Alcohol restrictions introduced by the WA government at the start of the pandemic were lifted as a reward to people complying with restrictions. And I guess WANATA's message is that we need a consistent message from government, from community services, etc., about the evidence-informed harms associated with drugs, including alcohol. That's me. Thank you.
Thanks, Jill. Gold star for being exactly 5 minutes. Thank you, Jill. I'm now going to hand over to Ketty Crystal from the Women's Council for Family and Domestic Violence. So, Ketty. Ketty, I think you're muted.
Sorry. Thank you. Good afternoon. So pre-COVID, refuges across the state were full, counselling services, safe at home services all had wait lists. So we were already in a very difficult situation before COVID hit. We also know from the research that has come out in the last few years around disasters that there is a marked spike in domestic and family violence following natural disasters or other types of disasters. So the predictions for our sector are that there will be a continual increase in the number of domestic and family violence victim survivors. The Australian Institute of Health and Welfare has put the peak spike at March next year. I'm not sure how they came to that month on what they've based that on, but that's their expectation at the moment. So I've tried to divide the talk today into different areas. So there was a large group of women that all the services were incredibly concerned about, and those women that were suddenly at home 24/7 because of social isolation with the person who was being abusive and violent towards them. So those women who may have been living in a situation with a partner's abusive, but may have been able to manage it or seek support previous to COVID, they may have had connections to family or friends to give them some relief, they lost those immediately. The impact of COVID in many cases would have increased the severity of the violence that those women and children were experiencing. The impact of job losses, travel restrictions, poverty, the increased use of alcohol, which Jill's just talked about, the rise in mental health issues, all of those things would have driven the severity of the violence and the abuse that those women and children may have been experiencing. There was also reported increases in online gambling, which would have affected their financial situation, and online pornography, which may have contributed to increased sexual abuse within those family relationships. So that group of women was incredibly hard to reach during the COVID period, and data on the numbers of those women has been very hard to ascertain. So during the COVID period, we had some data that showed an increase in police call-outs in the metropolitan area for domestic and family violence, but we also had drops in domestic and family violence at Fitzroy Crossing and Meekatharra. So Aboriginal women then in those areas had a reduction in the amount of violence they were experiencing due to the less access to alcohol and less movement of people in the communities there. One of the things 1800 Respect, the National Helpline, reported was that they were experiencing an increase in calls and web chat between the hours of 2 and 4 a.m, presumably from women whose partner was asleep at that time. We also heard reports that the trauma ward at Royal Perth Hospital, which usually is the place that road traffic victims end up in, was empty of road traffic victims for a period of time, and the people in there receiving medical assistance were all domestic and family violence victims of severe violence. At the same time, we had all our refuges full. Refuges were an essential service during this time, so the refuges, particularly in the metro, were all full. Refuges in the regions had to reduce their capacity to make sure they met social distancing requirements. So refuges in the metro then had to reduce and restrict the amount of movement the clients in-house had during that period. So a woman in a refuge will go out for appointments, may catch up with family and friends, may go and do shopping, may have, a fair amount of movement. During that COVID period, refuges had to restrict women from going shopping down to once a week, to restrict them from being able to connect with family and friends, allow them only to go out to very essential appointments. So then we had refuges with very stressed families, all living under conditions that didn't help, basically. Some refuges were requiring women to social isolate for 14 days when they came into the refuge, where they had capacity to put them into unit accommodation. So refuge staff were investing a huge amount of time providing emotional support and creative activities and physical activities for these women and children in refuges over that COVID period. Then when schools shut down, the requirement to do homeschooling, I think, was a particularly extremely stressful requirement for those mums living in refuges at that time. So that was and I want to talk about the needs to support our staff a little bit later on. The other area that domestic violence services had to really rapidly respond to was all their counselling and outreach services suddenly had to find ways to reach women while their staff were working from home, and to reach them through a whole variety of technology, from Zooms and Skypes and phones and web chats and a whole range of ways to try and reach their clients. Women's Council has been running a survey, so we've had 54 responses to the survey, which we're currently compiling at the moment, but the early data was showing that 46% of clients didn't have access to technology so that staff couldn't actually reach them, particularly in regional and remote areas. 41% didn't feel comfortable using tele-support options. 30% felt it wasn't safe to have this option in their home. 75% of DV staff hadn't received any training whatsoever in terms of delivering tele-support, and only 36% of staff felt very comfortable using technology. So this is a whole area that we have to do some training and upskilling and very quickly going forward, and if we have another resurgence of COVID.
Sorry, Katie, 30 more seconds.
Okay, I just dropped one out. I'll miss out the mainstream services. I just want to talk to support to staff. Regional refuges with Aboriginal staff reported staff going back to country and not being able to work due to their own health concerns. And DV services generally have reported that staff needed a significant amount of increased support themselves to manage their own mental health and their own anxiety levels because of the increased demand that clients were making on them for emotional support. And this is a huge area that we need to get better at doing. And currently Women's Council is going to run 2 workshops in September to try and draw up all these learnings from this experience and get a report happening. That's a very quick version.
Thank you, Katie. And we can make further information available after the webinar as well. So yeah, thank you very much, Katie. I will now lastly hand over to Jane Chilcott, the CEO of Linkwest.
Thanks, Kylie. Hi, everybody. So just if you haven't heard about Linkwest, Linkwest is the peak body for what we call neighbourhood and community resource centres in WA, and our vision is vibrant, inclusive, connected communities. So we really, our member base, which are community managed, place-based, not-for-profits, 120 of which are rural, regional, and remote, work in the prevention and early intervention. So they're in a pre-COVID survey that we conducted last year, 71% of those organisations were providing activities and services for people at risk of social isolation and loneliness. If we could have next slide, please. And in fact, what those organisations, some funded by Department of Communities, others funded by Department of Primary Industries and Regional Development, actually have built into their contracts community building, community-led development, reduction of social isolation, particularly the Department of Communities funded services. So during COVID, we did a bit of a pulse check across our membership base, and 96% of them continued providing services of some sort or another, and 78% of them successfully pivoted their services to online activities. And that's actually been a really positive outcome, because in some cases some of those people got better engagement with some of those cohorts than they did prior to COVID. So an example of that would be one of our centres in the Wheatbelt decided to run a bingo, online bingo every Friday night, and they were getting 50 people joining online bingo, including some people who had left the town and moved overseas, and they were joining as well. So that was actually a really positive outcome. We also noticed, and the centres also noticed, that necessity is the mother of invention, and quite a lot of the cohorts who had been reluctant to use digital technology or Zoom were engaging better during that period. 60% of the centres, and 48 of those were CRCs, who are all rural, regional, remote, and 76% of the neighbourhood centres identified that the greatest need to be addressed during COVID was social isolation, loneliness, and community disconnection. And that's what they would targeting through their delivery of online services. The other things that they did was they, because again in small communities they tend to know a lot of people, they were doing telephone trees, calling people who they felt might be vulnerable, dropping off supplies, trying to encourage them to connect in other ways, delivering books and videos. The most vulnerable group identified by 71% of the centres were seniors. And the difference between the difference in percentages there between the CRCs and the neighbourhood centres is all of our centres do a lot of work with seniors, but the neighbourhood centres do a lot of work, a lot of their customers, their centre users are families and with young children, which would explain that difference in percentages. What's distressing for our members, the centre managers, is last month we did another small sample of centre survey, because now they're all opening and the groups are meeting again. And the most vulnerable cohorts, so seniors, people with chronic health issues, potentially people at risk of family and domestic violence, have actually stopped using centres. Significant drops in some of the groups that they had been running successfully prior to COVID are now not meeting and have dropped off completely. So re-engaging with those people is extremely difficult, and engaging with them in different ways. So I'm just going to talk about risk of loneliness. So we talked about some of the drug and alcohol, mental health, and family and domestic violence. But in fact, everybody is at risk of social isolation and loneliness. And the times we're at risk is life transitions. So obviously COVID has actually exacerbated that in terms of the number of people who've been made unemployed, forced early retirement. So there's a significant increase in life transitions where we lose contact with our previous networks and therefore become at risk of social isolation. All of the previous presenters have talked about digital disadvantage. COVID really exacerbated and highlighted that digital disadvantage in all its forms is actually a compounding factor for loneliness and risk of loneliness. Physical distance. So the principle behind our organisations are they're pretty much within walking distance. So people who don't have transport, and in obviously small, rural and remote, there's very limited public transport or none. The physical distance to the nearest place to connect and meet makes a big impact. So in the rural areas, the people that the centre staff were most concerned about were the seniors who were stuck on rural properties, who couldn't come into town for any reason and were very, physically isolated as well, or people with disabilities.
Jane, sorry, another 30 seconds or so.
Okay, so low cost, no cost options are really important. Particularly for people experiencing family domestic violence and in poverty. Stigma we've touched on, and lack of associational life, I'll just touch on that. The more associations, whether it's sports, arts, history societies, etc., the more associational life there is in a community, the less risk there is of people suffering loneliness and social isolation. That's it for me.
Amazing. Thanks, Jane. And thank you all to all of our presenters. I think, there was a really rich amount of information shared there about the different kinds of impacts across the different kinds of experiences that people in our communities are facing. And I hope that all of you got as much out of that as I did. So I'm now going to split us into breakout rooms. Into the chat function, I'm just pasting a link to a Google Doc. And so if it strikes you while you're talking to put some of the points from your conversation into that document, it would be really valuable because this is, I guess, in part an engagement strategy for us to get as much feedback from all of you about the kind of content we've shared here. And so the questions we have for you, and I'll make these available in the breakout rooms too, are what have been your observations and experiences of the impact of COVID on social isolation? And the second question we have is, how do we encourage community connection and ensure that vulnerable and at-risk households are at the heart of social recovery. So I'm just going to divide you up now, and you will get a little invitation inviting you to join a room. So I will do that now. So does anyone want to, we probably can't hear from every group, but just in the last 7 minutes, does anyone want to feedback from their group? Jess?
Sure. So Taryn had to duck off, but we had a great conversation about what could be done within the community sector for people that are missing out. And the two key themes that we had were observations that particularly in emergency and financial relief spaces, there's not really a focus on the customer user journey or design thinking. It seems to be that organisations are focused on efficiency, and also that the government contracts that they're working within don't really enable enough space and time to engage the people who are the end users. And so that means that sometimes accessing that financial relief or food relief even becomes a full-time job and just keeps people in the cycle. For example, if you have to travel from your home to the food bank depot or somewhere else in the interim and pick up a voucher and then to food bank and then back home, that's a whole day gone, particularly for someone who's facing high levels of anxiety or financial stress or vulnerable to a virus like COVID-19. So government contracts enabling the sector to work with more of a focus around co-design or design thinking and understanding the user experience to streamline that and treat people more like customers than I suppose beneficiaries or charity recipients was one thing we touched on. And the second one was once again government taking the lead on us being smarter with how we capture data around people's user journey, because at the moment each organisation is capturing various quality and quantity of data. However, until it's streamlined, we're not going to understand what a day in Joe Smith's life looks like. So and Kylie, I know you've done quite a bit of work around social impact measurement, but just, I mean, we won't get it right, but for government to take the lead and say, this is the data that we need you to capture, here's some funding to get everyone up to the same page, and let's just start with that and build on it year on year. That was kind of the two key points that our team came out with.
That's great. Thanks so much for sharing, Jess. Does somebody else want to share? I think Jane. Not Jane, Linkwest, as much as we'd love to hear from you, Jane at Linkwest. I think Jane in another group was going to feedback.
Thanks. Thank you, Kylie. Yes, I'll feedback. One of the things that we identified was that perhaps older people were slightly more resilient as populations in that it was, if they were already somewhat disconnected or socially isolated, COVID was just normal for them. They were already in their homes, and that some of the people in our group found that the younger people struggled with it more. One of the other things that we identified was that it was a motivator for perhaps the older people, some people who were perhaps not connected digitally to do so. I'm aware that the City of Mandra's Seniors Centre Facebook group membership went from 250 to just under 1,000 directly as a result of the centre closing and them all coming out. So it was a positive benefit that people were becoming more motivated to go online.
Yeah, thanks, Jane. And, you know, a lot of them connecting just with one another without any kind of, you know, intervention or anything, right? I think we saw a lot of that as well. Are there any final feedback from any other group?
We probably, just to add to any of the other comments that were there, also spoke very much around the role that communities that did rise up and to connect with individuals within their communities. And for some of the other comments I also spoke about was also around the peers and the role that peers and peer work played in assisting people to either navigate or to find supports and services. Very much there was also the thought that the fact that we had to step outside and reach out and deliberately connect with individuals, and things that perhaps made us also think more around how important that is to be doing that and being the ones to make those phone calls as opposed to being stepped into and requiring consumers and individuals to actually step forward to seek support that they were being reached out to. and that was a really significant thing. I'm not sure if I've missed some other points that were raised as well. There was certainly a lot of barriers around, and people accessing online if they were not willing to, or not wanting to, or not having access to.
Yeah, absolutely. Thank you, Lisa. And Jill, did you have something to wrap up with?
Yeah, I wouldn't mind just mentioning, so rightly so, it was raised at our group that the called communities, you know, didn't get much of a mention. And Isha have done it, and other group members please step in, but Isha have developed a webinar that supports some initiatives, that may support some initiatives in regards to engaging with called communities. There's also been some funding to support some social and health research through the Edith Cowan University, with a specific focus on seniors and other vulnerable population groups. And I guess that many of the things, you know, like community, looking at community strengths that are existing, identifying some digital or data awareness as well to support any initiatives moving forward. And I think that's probably it for me. But please others step in.
Thanks, Jill, and I might draw it to a close there. So thank you everyone for engaging in that conversation. For such a kind of big topic, we were a little bit like, oof, you know, how do we address this? But I want to really thank our presenters, Jenny and Alex, Jill and Jane, and oh no, I'm going to forget them. No, Taryn and Ketty. So thank you so much. Thank you for participating. There will be an evaluation go out, and we'd really, really appreciate your feedback on that so we can continue to improve. And I also just want to draw your attention to the fact that 100 Families will release its most recent set of findings, and that there will be a launch of the findings at the State Library on the 21st of August, but we'll also make sure that those registered for the webinar have access to those findings as well. So thanks so much everyone, and enjoy the rest of your afternoon.